evening. Welcome to tonight's Virtual Fellows Conference. This is a 16-week virtual program under the leadership of ASES President Bill Levine. Tonight's session is Grade 3 AC joint in a young active female with hyperlaxity. Our moderator is Dr. Stephen Brockmeier. Our panelists are Dr. Mike Griewe, Samar Hasan, and Brent Morris. Please feel free to ask questions. Myself as Education Chair and Dr. Levine will be managing the chat room. And with that, I turn over the program to Dr. Brockmeier.
All right, thanks Ron John, and thanks Bill. Really appreciate the invitation to be a part of this, significant undertaking. It's been pretty impressive to pull this together quickly and kind of give this type of content to the shoulder and elbow fellows out there. Given what we're all kind of living through right now, it's always nice to take some time and exercise the brain and interact and get together with people, at least virtually at this point in time. And so looking forward to an interesting discussion. I think the plan is to make this like the other ones, so be very interactive. For the fellows and for all the participants, people who are logged in, feel free to submit questions via the chat. Let's make sure we make this as interactive and as fun as possible. So as Ranjan said, my name is Steve Brockmeier. I'm at the University of Virginia, and I'm here with 3 people from the Midwest, 2 from Cincinnati, Ohio, 1 from Kentucky, Mike Griewe, Samar Hasan, and Brent Morris. And so we're gonna talk on this interesting topic, Grade 3 AC joint in a young, active female with hyperlaxity. Hold on, and now I can advance it. So first, we'd all like to thank our sponsor for this web series, DJO, for their generous sponsorship of all of these. And so thanks to DJO. I went ahead and just put this slide up. I took the disclosures out of all of our talks. We all do have disclosures posted on the Academy website if anybody has interest. And I believe that this forum will be very much biased and bias-free as we talk through these topics. So I'm going to let Dr. Hasan give us the first talk. And I don't know whether it was coincidence or not. This is a very unique topic, Grade 3 AC joint in the hyperlax adolescent female. But he has essentially the perfect patient for this. So we're going to start off with a case and some discussion about this particularly interesting, challenging problem. So Samar, go ahead.
Thank you very much, Dr. Brockmeier. It's great to be part of this. And yes, I'm excited to be on this panel, in particular because as these clinical vignettes were distributed, I looked at this and I said, oh my God, I've got the perfect case. And I had just taken care of her literally a couple of months before these assignments. So thanks for allowing me to share this, and hopefully this will segue to a hearty discussion on this topic. The next slide. So this is a patient who's a 15-year-old high school basketball player who was actually referred to me by one of the sports doctors at the local children's hospital after they had kind of exhausted all the conservative treatments, basically for a second opinion. She had come to us with a 2 to 3 year history of right shoulder pain and instability and had a diagnosis of MDI. She had bilateral hyperlaxity, but again, symptoms only on the right side. To confound matters, or to complicate matters, she had also fallen off a chair while rehearsing a scene in a high school musical and suffered an AC joint separation, and then acquired this volitional AC joint instability, which she actually was kind enough to videotape. If you want to run through that, hopefully it'll play. And so she had this ability to basically pop her AC joint horizontally, translated, and she did not have that ability on the opposite side. And she didn't do this, you know, to gain attention or anything. She was very, very, you know, kind of great demeanor. And I felt very comfortable, you know, taking care of this patient. But clearly, I felt that whatever she had, that combination of this instability of the glenohumeral joint and this AC joint instability that was acquired was going to be quite challenging. She had pain with prolonged activity. She had pain when she kept her arm in one spot for a long time. And she was really struggling participating in basketball. Next slide. So her physical exam included signs of generalized sort of instability, 2+ inferior sulcus, positive anterior and posterior drawer, about 2+, and this kind of right-sided AC joint hypermobility that seemed to have mostly a horizontal, but to some extent a vertical component. She had an apprehension. She didn't have a gross sort of jerk or clunk, although again, she had this painful looseness, if you will, in both directions, tenderness over the AC joint, and a palpable click over the posterior joint line. Her Baton score was 8 out of 9, and so we clearly had this kind of generalized laxity underpinning. Next slide. She had failed over a year of physical therapy by a therapist who I knew personally, and this included 6 months of conservative treatment for MDI, and then this AC joint injury, back to the drawing board with 6 more months of work on periscapular mechanics and rotator cuff strengthening and trying to improve her dynamic stability, but she had no overhead performance endurance, was really struggling. And you can see here plain radiographs show some upward migration of the clavicle relative to the acromion. Next slide. And on the axillary lateral, no signs of any gross sort of posterior translation. The MRI, this far out from her injury, it really just showed again a patulous capsule, very subtle labral changes, no discrete detached labrum. We did not get a CT scan. I didn't feel that this was a case of glenoid bone loss, no large Hill-Sachs defect. Next slide. We can run through these really quick, just kind of just showing again an MR with contrast, showing a patulous capsule, but no gross tearing. Next slide. And not a whole lot with regards to the AC joint, maybe a little bit of elevation of the clavicle relative to the acromion. But again, she has this clear-cut instability, this painful ability to translate her AC joint. And so given the treatment options that we discussed, we're trying to live with this clearly. Physical therapy was brought on, but clearly after over a year of physical therapy, the likelihood of incremental benefit was diminishing. And her treating physician had actually recommended doing an open AC joint reconstruction and then possibly doing a later capsular plication down the road. And my concern was that the clavicle was really going to be important as a strut, if you will, to help anchor the scapula and the periscapular muscles. And so I told him that if this were my patient, that my approach would be to treat both of these concurrently, fix the labrum arthroscopically, and then opt for a minimally invasive technique to reduce the AC joint and then augment it with an allograft. And they decided to have me take care of her, or take care of this 15-year-old. And so let's go to the next slide. And so what we did was we did an arthroscopic capsular plication followed by an arthroscopic AC joint reconstruction, or arthroscopic assisted, with an allograft cerclage. And this is her exam under anesthesia, just showing again a pretty significant sort of looseness, if you will, on exam, and this hyperlaxity of the clavicle. Next slide. So obviously the talk here is about AC joints, so I don't want to belabor the labrum repair. She did have a small labrum tear, actually, both anterior inferior, posterior inferior. So we just repaired the labrum, did adjunctive plication, basically 180-degree capsulolabral repair with suture anchors. Next slide. These are, again, just some sort of pictures. I tend to like to tubularize the labrum, but again, that's beyond the discussion. And then just closed her portals with 4-0 nylon and repositioned her in a beach chair position. Now, AC joint reconstructions and repairs can be done lateral decubitus, but I had to go with what I was most comfortable. I do my labrum repairs and my instability repairs that are arthroscopic in a lateral decubitus position, but I do most of my subacromial work and AC joint work in a beach chair, and I was more comfortable. It did take some extra time, and I like to have C-arm available. Next slide. And so we're going to go ahead and just do a 3 sort of minute video that summarizes the technique that I employed. I switched to a 70-degree scope right away because I'd already scoped her shoulder with a 30-degree scope. And so we make a small incision over the lateral clavicle, use an ACL guide to guide the placement of a cannulated drill, and under fluoroscopic guidance, bring it center, use a wire that can be passed through the center of the drill to help us deliver a 4-strand high-strength tape-type construct with a button And when I started doing these, we delivered the button sort of antegrade, but that meant making a larger bone window. These are larger buttons, so they seem to be safer in terms of not perforating through the coracoid, and we can kind of guide that button down inside. And so I'm kind of flipping here between a view from our outside camera and then showing here what's happening at the base of the coracoid as this button is being delivered. And then we'll cinch down on those strands individually and sort of cinch things up. And I have to tell you, normally my visualization is better, but I really tried to reserve her rotator interval. And I was working through a very tiny slit, so really kind of struggling, but I think the video is reasonable. And then the second button is then secured to these tapes, again, centered on the clavicle, about 4 centimeters in from the AC joint. I did not do a distal clavicle excision. I will do that in older patients if they have an irreducible AC joint. But in this case, I left the AC joint in this young woman alone and just focused on providing this construct to stabilize the AC joint and reduce it. And we typically try to over-reduce it just a little bit, knowing that in general, as they start to get more active, there's a little bit of stretching, just a little bit. And so now what I did is I wanted to augment. This is a chronic case, and really I've moved to doing this for even those select acute cases that I do, is we're gonna deliver a tibialis anterior allograft initially from behind the clavicle to medial to the coracoid. And I use this kind of semi-rigid suture that I then retrieve and pass that onto my double whip stitched allograft and bring it out, leaving then part of the allograft anterior. And now I'm gonna go with a switching stick and a dilator over it, anterior to the clavicle and lateral to the coracoid. That's usually considerably easier, and doing the same process in reverse. So I basically have a loop of the allograft around the base of the coracoid and then around the entire clavicle. And this is a technique that I learned from Dr. Peter Millett and have used probably for 8 to 10 years. And we actually had a little problem with their camera at the end. So just to finish, what we do then is it's really important to lock that loop of allograft. So we'll stitch it with the sutures from the button on the clavicle, and then I'll leave one strand long, and I'll basically lift up and use that to shore up the delto trapezial fascia and also across the AC joint capsule with a couple of sutures. Sometimes we have to make the incision a little longer. This patient had stretchy skin like she had stretchy everything else. And so we could do this through a relatively small incision. Next slide. So we keep her in a brace. I always try to look for a safety factor. I tell patients, 4 to 6 weeks, and if at 4 they're doing well and starting to get pretty stiff, then we'll move things along. And we started an active assisted range of motion program, playing to the scapula, added some exercises, and she's now at 11 weeks. This is kind of a midterm. Next slide. And you can see the buttons, how they look on the AC joint, again, reduced. So let's see how she's moving. So at 11 weeks, this is her lifting her arm up. Still doesn't have perfectly normal kinematics, but she seems to be doing pretty well. And then I'll show you the inset in just a second as we wrap things up. And let's see her turn around. You can see here she doesn't have normal rhythm. So you can see a little bit of a hike, but this is at 11 weeks. And I felt comfortable enough based on how she was healing. And if you'll go to the next video, I asked her to try and voluntarily dislocate her AC joint, and she couldn't. And so I felt that was a good thing. Next slide. This is the last one. And I just saw her a couple of weeks ago. We have one more slide. At 17 weeks, basically she's now transitioning to sports. Let's run the video because you can see an improvement in her scapular rhythm and her shoulder kinematics. So again, very good movement, very confident, very happy. We'll just run the video. And so again, self-assessed scores, obviously they have a little bit of a ceiling effect. The real true mark of success will be returning back to sport. And of course, we don't know if they're going to be sports in a conventional sense, even this winter, but she's being cleared. She's doing some advanced training, and I'll do isokinetic strength testing at 6 months as a final check. So thank you for allowing me the privilege to share this case. Thank you, Dr. Brockmeier.
So I'll ask the other faculty to kind of unmute at the moment. Looks like Dr. Levine is also unmuted, so maybe there's some audience questions, but kind of an ideal case. I thought it was interesting that you decided to take on both simultaneously. So you mentioned, and I know this is, it's because of her multi-laxity, she's probably a perfect patient for it in the chronicity, but you said you use a graft for all patients at this point in time, Samir?
Yeah, you know, I have. That's not how I learned. When we learned this technique, and as a lot of you, I'm sure, I learned and followed Dr. Mazaka's work on this and did the so-called Mazaka technique, but really was interested in a minimally invasive alternative. And the barrier to me was these large windows in the coracoid. So all this talk about doing grafts embedded in a construct with 6 millimeter holes, I never did that. Clearly this one, which is a 2.4 millimeter hole to me, and I've done 3 of them since her, so I do a fair number of these, I'm very comfortable doing, and I have yet to see the catastrophic problems that have been described, recognizing that it may be a matter of time. But when I got comfortable doing Dr. Millett's technique, and I'll tell you, it took a while. I mean, these cases take a while, and sometimes I'll struggle for 15 minutes, you know, trying to get the switching stick just right. But you know, for me, again, I'm willing to do that, and I feel comfortable doing it. And for me, what that allows, meaning doing a graft on all cases, allows me then not to prejudge my patients, because my treatment for acute, which I do infrequently, and chronic is essentially the same. And so that means that the majority of cases, I'm going to treat after a trial of conservative treatment. This one, obviously, you know, she was done. I mean, she had the look on her face. Her mom had the look on her face. The doc who referred her was one of our fellows 15 years ago. I talked to him. He said, please help me with this patient. And so I was ready. And the decision to do both of these, I admit, was, you know, I knew I was buying, you know, 2.5 hours plus maybe 20 minutes, 30 minutes in between to set up and do everything over again. But I thought it was the right thing to do. And it seems to be at short follow.
Hey, Samir, it's a great case, and thanks for presenting it. The question that comes up is she's 15 years old and she's got collagen hyperlaxity issues. So there's a lot of people in the audience right now that are wondering, how soon is she going to fail, and when is it going to happen, and why operate on her at her perhaps most hyperlax time of her life? If you could get her to a few more years, maybe she gets a little tighter over time. We've all seen these people. And so how did you, I know you presented that she kind of, quote, failed non-operative management, but how did you decide to pull the trigger at this age?
So, you know, there are a couple of things with these type of, whether or not she carries a diagnosis of Ehlers-Danlos, I think is probably secondary. She's hyperlax, she's got a collagen disorder, whatever you call it. I will tell you, she didn't raise a lot of the red flags. Her pain levels were low, and she clearly had this unilaterally. She's so well adjusted on the other side. She's got great scapular rhythm. She moves. She's an athletic type who's still playing through this. So there were a lot of these intangibles that made me feel more comfortable. Might she fail? Of course. I'm well aware of that. But I also think that I give her a chance, and that perhaps if she is to stretch out, it might be the glenohumeral joint. It may not be the AC joint. And so for me, this was, we had a really nice shared decision making. She's a very bright gal. Her mom is highly educated and intelligent. And so, I mean, this was an office visit that took well over an hour, and had a follow-up visit a week later. So I mean, that's the best I can answer. I mean, I think I'm being evasive. I don't think so. I think this is honestly, I didn't think she was going to wait another couple of years. That would mean likely the end of her ability to grow in athletics at a school that is a sort of a high school powerhouse for girls sports, and she really wanted a chance to participate.
Thanks for explaining that. I think that helps people understand your thought process and decision making.
Thank you.
All right, other comments or questions for this case?
Nothing from the chat room, I think. Move on to the next one.
All right. Well, Samir, that was fantastic. Makes my cases look very, very pedestrian. What we elected to do is also cover some other areas within AC joint that may complement the original case. This is a talk that I was actually slated to give. Well, this was an adopted talk that I was slated to give at a meeting that then got canceled. But basically, this talk focuses on the contributions of the AC joint and reconstruction of the AC joint. And I thought it was actually it worked out at happenstance that in Samir's case, he did not address the AC joint, which, I found to be something that I think, especially in a case like that where you have some collagen disease, may be something that would be worth considering. So this is actually Eric McCarty's slide that I've used in the past, that he's graciously let me use, but a great quote: if you want to have complications doing shoulder surgery, operate on the AC joint a lot. So bear that in mind as you move forward with these cases. And I will give credit to my partners here in Charlottesville, and they were actually collecting this group of patients actually before I started. So I will have a disclaimer: none of these were actually my patients. That's why I like to show this paper. But this was a paper they published, I want to say in the ballpark of 2012, highlighting all of their many complications doing surgery on the AC joint. Samira, you can see this is one of those implants you were talking about there, where you drill these gigantic holes. This was, I think, a 6 or 7 millimeter hole with a graft incorporated. So kind of highlighting what you were trying to say there with your implant. So obviously this is a common injury. We see these all the time. Most, if not, kind of the great majority, do not require surgery, and many are the kind of the lower grade injuries. And so there's a number of things that I think we all continue to struggle with. And I think what we'll see here, because I'm obviously privy to what the other speakers are going to cover, is there's a bunch of different ways to skin the cat with these. And I think the key questions that we all kind of bat around in our heads and still need to answer better is when to indicate surgery. We talked about, or we just heard Samir's indications for that specific, very unique case. But just in the general traumatic AC separation, when do you actually pull the trigger early, or should you ever? And when do you try to see how things go and come at it from a delayed standpoint? What's the best way to fix these? Well, you'll see 4 surgeons present tonight, and probably 4 different ways of dealing with these. And then most importantly, what I'll highlight is try to avoid the complications and failures. So you got your treatment algorithm for these. You have what and it's very easy to Monday morning quarterback these, the stable versus unstable. The stable ones are the ones that you don't need to operate on, and the unstable ones are the ones that don't do well and you eventually need to operate on. But how do you really judge these on the front end is really an evolving area. And I think one of the other speakers is going to cover that better than I will. So I'll just leave it at that. And then we all have this, we're all familiar with the kind of the standard grading system for AC injuries, which I think we can all agree has some holes and some potential flaws. But in general, the low grades you leave alone, they tend to do fine. The high grades, I think many people consider operative, although there are circumstances where I'll treat those non-operatively, and I think many of us do as well. And then you have the grade 3s, which is where the controversy is, and that's why that's the topic of this particular webinar. So I'm going to show you 2 case examples. They're much more straightforward because there's not this collagen vascular or this collagen disorder and hyperlaxity component. So this is a guy, he's not an old guy per se, although he's not, your high school athlete. He's a 38-year-old. He's occupied as an airline pilot. He's right-handed. This is his right shoulder, and he fell off a road bike and landed on the point of his shoulder. Probably the most common mechanism I see for AC separations, I'm sure we all can kind of agree on that, outside of the contact athlete population. So you can see here kind of side-to-side x-rays where this grades out, as kind of essentially a type 5 based on the way these lines are drawn. You can make the argument that it's kind of like a high 3 or a low 5, but this is one that arguably might factor into surgical management. So very quickly, for the panel, for Bill, for Ranjan, who operates on this guy? Brent, go ahead and start with you, man.
Yeah, so we'll hear a little bit, Steve, about my approach to these, but I'm going to examine this patient. To me, it's not a 2-dimensional, you get one 2D x-ray, it's a 3-dimensional problem. So I'm going to look at his scapula. Samar brought that up a little bit. Look at his scapula, see if he is a compensator. But I think given his history, I think this is going to be one who, with, again, shared decision-making surgery would likely be the way. I'll see him at acute injury time. I'll see him 10 to 14 days later, reassess, give him a chance to chew on the options, reassess his scapula, see how he looks with some dynamic and manual testing, but likely operative here. Okay.
Samir, what would you do?
Yeah, I would agree with it. I would agree with Brent. I would examine the patient. I mean, clearly the intangibles here, he's a pilot. Those guys don't like to be still. He likes to go cycling. I think folks that do a lot of cycling, whether it's road or mountain, generally are going to do better, I think, in most cases with their AC joint stable or stabilized. But I agree, he needs a careful exam and then a shared decision-making or discussion about treatment options.
All right, so let's say the exam, though, demonstrates some of those things you guys are highlighting. This is one you'd be comfortable proceeding with a surgery in the shorter time frame versus delayed watch?
Absolutely.
Yes.
Hey, Steve.
Yes.
I'd have no problem treating this non-operatively, and I'd love to see what Sammer's telling us. Airline pilot's going to do better with surgery. Where is that in the Journal of Irreproducible Results?
No, that's not what I meant. I'm just saying that a lot of these folks are going to be taking time off, and again, maybe they're on furlough right now. Maybe he's going to have 6 months to rehab, but those folks tend to be, when can I get back? When can I get back to do my thing? And they won't, so they tend to, want to get the most direct path and to get back to riding a bike and so forth. And I worry that if they fail with a prolonged non-operative course, then I'm just delaying the inevitable. That was really the intent of that.
No, I'm all kidding aside, though. There is a physical exam maneuver, Steve, that I think is important to talk about. And Carl Bassamania talked about it a long time ago, and it hasn't gotten a lot of play, but he also described an X-ray view for it. And so for the fellows, if you've never seen this, bring the forearm into forward flexion 90 degrees and maximally cross-body AD duct. And there's a certain subset population of cohort of these type 3s where the clavicle, the acromion will slide underneath the clavicle with that adduction maneuver. And those are the ones that become unstable. Those are the ones not unstable. Those are the ones that are painful and symptomatic. So we've all seen a lot of type 3s where they do surprisingly well. They never get surgery. And that's a physical exam maneuver you can use to try to decide who might be that guy that is going to have a very painful and unstable one that you might want to do something earlier on.
So, Bill, are you talking about like a view like this at the bottom right?
Exactly.
Yeah. Yeah, so Basmania view. And I agree with you. And I think that's one thing to obviously look for. You can kind of get a feel for stability and instability when you examine these patients. I think that's what you're hearing from all of us. Mike, do you have anything to add here? What would you do?
No, I think you guys said it pretty well. One of the things that I do when I'm trying to decide between a 3 and a 5 is I might use a weighted arm view. So I might add 5 pounds to the patient's arm, and that really will show you a type 5 pretty clearly. So I've used that a few times just when I'm trying to understand the difference between a 3 and a 5, and I'm trying to make a decision between surgical versus non-surgical. So that's been a helpful radiographic view for me as well.
One other thing too, Steve, maybe it's just me, but I think for the fellows to know it, a lot depends on the cycling groups. I know that sounds crazy. We can debate this all night, but if you have a patient, I've seen several of these I saw in Houston at least, 65 to 70, high grade 3B up to 4 or 5, typically 5s, who say, hey, I've had 6 friends who've had the same injury. None of them had surgery. They're doing great. And then a different cycling cohort, they have a different opinion. They show up, I'm 38. I want this fixed. So the patient matters. We can decide all we want on indications, but they have an agenda sometimes, and it's our job to guide them. But some of those patients that are committed to non-op, high grade 3Bs or 5s, I've been really impressed with how some of those do. But they come in with an agenda based on prior experiences with friends in their riding group. So keep that in mind.
Yeah, I agree with you. And as you'll see here with a lot of these cases, kind of clear as mud, right? So, in the end, what's the indication? We'll figure it out hopefully at some point. Here's another one, not much of a different injury. I don't have the comparative view, but take my word for it that this guy was very similar, unstable injury, and even a more higher riding type 5 type injury. Do you think age matters? I think most of us would probably agree that an 18-year-old versus a 35-year-old probably not much, or a 38-year-old not much of a difference, correct? All right. So here are the key questions. So does surgical management differ? And I think as we talk through the different ways that we manage these, we may want to highlight these. Can you get away with no graft if you don't operate on them? I'm with Samir. I actually use a graft for all my patients. And so that doesn't impact my use of the graft. There are some of these with concomitant pathology, so don't forget about that. Maybe they have another injury. So be thoughtful about that. I like to repair the AC capsule, and I'll show you a video of that. And so I do think the earlier you get in, the more likely you'll be able to do that with good anatomy. So, maybe there is some benefit, but I don't think that's been in any way supported by the evidence. And so is there an appreciable downside to waiting? I don't think that question's been answered yet. And so then to follow up with that, can we really manage all of these with a period of observation and see who fails? And so I think that's the key question. I'm going to rifle through these. There are some studies that try to answer this question. I would tell you a summary of it is that we really honestly don't know. This is a pretty good study, and it actually kind of refutes the concept of the pilot getting back quicker with an operation. Really what it showed is that people actually get back quicker if you don't operate on them, and they do okay. The problem with this injury is there's 1,000 techniques, and there's not one that we all use. There's 4 speakers for this talk, or for this webinar that were chosen, not by design, and we all do this differently. You can see down here is the one that Samir showed, a good technique. Here's where that technique can go awry, so you got to be really cautious with how you carry it out. So here's how I do it. So strong construct. I like to use the kind of this thing on the right. I'll show you the video of that. I did for a while use this lockdown device, but it's a little finicky and it's not inexpensive at all. I do a graft in every patient. I do the same thing that you just saw, where I loop it around the coracoid, loop it around the clavicle. I don't think drilling holes in the clavicle is a great idea, especially in a contact athlete or a cyclist who may fall again. And so I tend to do this, and that's based off that complications paper that my partners published, where they actually had a few clavicle fractures. So you got to be thoughtful about how these can go wrong. And I really am an advocate of addressing the AC joint. This was a more chronic injury, so this was more of like a graft reconstruction of the AC joint. And I'll use maybe sometimes an internal brace. So here's that first case. I did operate on him. I used a lockdown device in him. That's what this looks like. It's this large kind of Gore-Tex tape type device. It's got a loop on the end. You shuttle it around the coracoid like this, and then you do a luggage tag through the actual implant, and then you bring it around the back of the clavicle and reduce it. So you'll see that we kind of have the clavicle reduced. It does require placement of a screw, and it comes in increments. So if you have the exact right size, like this, it works out well, but sometimes that screw ends up being high or ends up being low to make it fit. You can see a graft here, and then you can see a suture anchor-based repair of the AC capsule in this patient. We did him early, and so we were able to fix it. I tend to use actually a smaller anchor now. I use a kind of a 3.5 sized anchor versus that 4.75 you saw there. But it gives you really good 360-degree, both AP as well as superior inferior stability with that kind of technique. And so you can see his x-rays there. Here's this 18-year-old guy. Again, he got surgery. And here's the other technique. And I apologize, the video quality is a little bit weird. It's got this kind of sheen to it, but you can kind of get an idea to what we're doing here. So first of all, I use a FIBERTAPE. No disclosures for me here, obviously, on FIBERTAPE. I wish there were. And bring that up through a small drill hole. And I use that DOGBONE device superiorly, but I wrap it around the coracoid. So I do a luggage tag around the coracoid and then bring it up through. So not dissimilar to the technique that was shown before, but without coracoid drilling, which I think for me is just a risky thing to do. And you can see here again, and this video was shot about 1.5 years or so ago, but a similar 4.75 anchor with a repair of that clavicle or that AC capsule and AC ligament, and gives you a really solid construct. So again, here's his final result. You can see the incision we use, slightly bigger than the one you saw there. I do these open. For a while, I did these arthroscopically, and I like that technique, but it doesn't allow you the ability to get to the AC joint unless you make your incision bigger, and that basically foregoes the benefit of the arthroscopic procedure. Follow a very similar post-op management protocol to what was shown with the last case. I tend to move these people really slowly, meaning that I have them in a sling for 6 weeks. I'm really just passive till week 6, then active. I go slow during the first 3 months. They solidify, and then you can move fast. And you can get them back to the weights at about 3 months. Cycling, normally I do about 4 months. That's about as long as you can hold these people off. And then contact sports at 6. Final case to show that you can use this technique to salvage, if need be, a prior older, but basically a failed prior surgery that we salvaged with this technique. Very quickly, we have started to look at this here as far as AC and CC combined with AC stabilization, combined to just CC stabilization. You can see we have these 2 cohorts, a bit of a mixed bag. Not all my patients, it's myself and one of my partners. But you can see here, loss of reduction is one of the key complications that you see with this surgery. And you can see a pretty clear difference between when you combine reconstruction versus CC only. Reoperations were certainly a higher percentage in the CC only construct, and some of these were for loss of fixation. And so I would suggest that perhaps AC joint, addressing the AC joint's a really important thing to do. Over the past probably 3 to 4 years, I basically do it in all cases. And I do think it's really helped from the standpoint of not only accomplishing a good outcome, but limiting the complications that we worry about in these patients.
Hey, Steve, there's a question from the chat room about the type of grafts that you're all using. Anybody using an autograft? And if so, which one? And if not, why? And then what allograft do you use if you don't use autograft?
So that's a good question. When I was first in practice, early in practice for quote, high demand or elite athletes, I did a couple cases where I harvested the semitendinosus as an autograft, but I stopped doing that fairly quickly. I use allograft. I use an allograft semi-T. It's an extra-articular graft, and I think works just fine for this. I'm curious as to the other folks here. What do you guys use?
So, Steve, I use tibialis anterior. I saved the semi-T allografts for the ACL surgeons, and used autograft a couple of times very early in my practice. But I really think that this is one of these joints that seems to tolerate it. We used to do it with Weaver done. You know, I started and I trained doing a Weaver done where it's just a wisp. So whatever we're doing now, I think is from a collagen, from a biologic standpoint, can't be any worse than a tiny wisp of that autograft. And the only thing I wouldn't use is posterior tips, because those tend to be degenerative. So tibialis anterior, certainly if I got my hands on a semi-T, that'd be fine too.
All right, Mike, what about you?
So I actually do use a posterior tip. Thank you very much, Sam, for setting me up. And I learned that from Bill Levine and his folks at Columbia.
You use, is it minimum patient age of 60?
Yeah, exactly. I want to make sure it's like at least a grade 3. You know, we check them, we make sure that the photos are there, and then we harvest.
I'd just like to say that I never have used a posterior tip in my life, Mike. So I have.
It might be Chris Ahmad. I don't know.
Something happened between New
that.
York and Cincy, my friend.
We'll have to get Chris on and see what's going on there. No, but I think the reason that we used it was because it added a little bit more bulk than a semi-T, and so that was sort of the reason you try to get, you know, a full 5.5 millimeter graft in the tunnel. So.
All right, Brent.
So semi-T allograft for our technique, it would be 6 by 260. That 260, just like you were talking about, Steve, allows you, you'll see the technique shortly, but it does allow you, once you kind of the Mazaka technique or modification does allow you to dock the remainder of the graft into the acromion. So that 260 is important. So my team here kind of knows what we go with. I did work on some things with some of my colleagues in Rome. They're using gracilis autograft, you know, so I don't know, it may be specific to where you are, access to allograft, but seems like most here use allograft.
Hey, Steve, could you just explain what the use of that screw was? I think you flew by that pretty quickly, and I've never seen that technique before.
So the name of the implant is called the Lockdown. It was developed in Great Britain. I'm not sure, honestly, who distributes it in the U.S. It may still be Lockdown.
Oh, so it's part of that implant.
It's part of that implant. So the way the implant works is it's basically a luggage tag, goes around the coracoid at the neck. It goes posterior to anterior over the clavicle, and then the screw basically goes through the device and anchors the device A to P on the clavicle.
Thanks.
For the panelists that use allograft, is there any indication that they would use an autograft for, or are they comfortable just using allograft for everything?
Allograft.
Allograft.
Allograft with some sort of, I guess, the internal brace, but some backup non-biologic, but always biologic with some additional support while the biology catches up.
Thank you.
All right. Any other questions? We can move on to the next topic here.
Next topic.
All right. Proceed. All right.
All right, great. So I get the controversial topic tonight. It's basically AC joint injuries managed by hook plates. And thanks very much for having me on the panel. I appreciate it, and looking forward to kind of going through the case. So next slide. So this is a 36-year-old gentleman who presented to the emergency department where I cover with complaints of pain after an injury he sustained in his left shoulder. So he had a fall, and he had some bruising just sort of posterior to the acromion, overlying the acromial process, and some focal tenderness over the acromion and the AC joint. He was unable to really actively lift the arm, and he was nerve ashley intact. Next slide. So these are his emergency department x-rays. Look fairly reasonable. There is a small bony fleck at the inferior aspect of the AC joint that you can see with the yellow arrow that our radiologist has sort of helped us by pointing out. But I had him come back to see me in the office, and you can go to the next slide. And he followed up with me a couple of days later. He was in a sling for sort of immobilization and continued to sort of have complaints of pain. He said, you know, the pain was fairly manageable. He had some swelling and bruising on the top of his shoulder. And on physical exam, he had a lot of tenderness and swelling over the superior aspect of the shoulder. There was clearly some elevation of the distal clavicle, was not easily reducible, was fairly swollen. And again, he was nerve ashley intact. Let's go to the x-rays from the office. So are his x-rays from my office. You know, what you can see again is that bony fleck inferiorly, and the clavicle is a little bit high riding. Let's go to the next slide. Let's go back one. So one of the things that I was noticing in the office was that, you know, there was something kind of not quite right on that right view there, right around the coracoid. So you can kind of point to the coracoid, Dr. Brockmeier. Yeah, right in there. So there seemed to be some type of step off there that looked like maybe he had some type of coracoid disruption. So it's a very interesting case because it was a subtle coracoid injury. And so I went ahead and got a CT scan. You can go to the next slide. What you can see here is that he really had sort of a base of coracoid fracture as well as an inferior AC joint injury. So bony fleck at the inferior aspect of the AC joint and a coracoid fracture. So he sort of had this sort of floating CC ligament area, which I felt like was going to potentially cause him some issues and problems down the line with potentially a painful non-union at the coracoid area. So let's go ahead and go to the next slide. So you can kind of see this is the axillary view, the axial view of the CT scans demonstrating a fracture at the base of the coracoid. Next slide. So, you know, at this point, you know, what to consider, and you know, sort of an interesting case. I was a little bit worried about the fact that he may have some difficulty healing around the coracoid. I felt like he was going to have some chronic instability at the AC joint. And so, you know, obviously you can treat this gentleman potentially non-surgically. There's also the potential that you could treat this surgically. So I'm interested to sort of hear from the panelists kind of what they would do at this point in time, given the nature of this injury, and kind of, you know, would they treat it non-surgically? Would this be something that you might consider treating surgically? Let's go with Dr. Brockmeier. What do you think?
I would lean towards surgery in this guy. I think this is a particular constellation of injuries where, you know, it could be that this kind of scars in, so to speak, acts like an AC separation, kind of like a grade 3-ish separation. But I agree with you. I worry about the component here that involves the coracoid, you know, versus just a CC ligament injury. It'd be one that I would be interested in because, frankly, you might be able to simply fix the coracoid and get away with only that. Depending on how things go. I mean, it depends on how kind of stable your construct is. It's not easy to reduce and fix a coracoid base fracture. I've only done it a couple of times, but haven't found it to be necessarily the slickest operation when I have. But I lean towards surgery in this guy more than likely.
Okay, anybody else favor non-surgical management here? All right, well, let's go ahead and go to the next slide. So here's kind of what I did, and you know, I felt kind of similarly that I wanted to be able to fix obviously the coracoid, but I was concerned about fixation, just like you said, Dr. Brockmeier. So you know, in my case, I was able to get a couple of screws into the coracoid piece. It was challenging to reduce. I did this open. I did think about kind of doing an arthroscopic assisted, you know, reconstruction here. And I think Dr. Hasan, you probably, with your work around the coracoid arthroscopically, probably would feel more comfortable doing that, because I think it would have been a perfect case possibly for like percutaneous screws. But ultimately, I did an open surgery here, found the base of the coracoid. It was displaced significantly. I was able to reduce it by sort of a window through the rotator interval. And through that, I was able to get things reduced and then place 2 partially threaded cancellous screws that were 4.0 millimeters into the coracoid base to fix it. But again, I did get good purchase, you know, with the screws, but I still felt like potentially I was going to have some, you know, some pull from the shoulder and the distraction from the ligament. So I actually added a hook plate here. So let's go on to the next x-rays. And so this is what I ended up doing. These are the kind of final post-operative x-rays with the hook plate. You can see I was able to gain some good purchase into sort of the hard bone of the posterior aspect of kind of the spine of the scapula. And I felt like I had a, you know, reasonable reduction as well. Let's go ahead and go to the next slide. So, you know, it bears mentioning, you know, has there really been a positive, you know, article on hook plates in the U.S. literature? And I think, go ahead and go again here. Not really that I've seen. You know, I think in the U.S. literature, there's a lot of sort of outcomes that show a lot of complications with hook plates. And so I really actually try to stay away from hook plates with AC joint reconstruction. But there are a couple of times when I consider using it. And we'll kind of go through that at the end of the talk here. Let's go ahead and go to the next slide. So what are the pros with managing AC injuries with a hook plate? Number one, I think improves post-operative alignment at early and late time points. So as long as you don't have a complication from the hook plate, you do maintain reduction. I think in all AC joint surgery, the biggest issue that we see post-operatively, the thing we hate to see is when that clavicle sort of slides up on us. You know, it definitely happens. I mean, you know, I do like a regular, you know, CC ligament reconstruction. I kind of use the Mazaka technique. And, you know, you may treat a 40-year-old patient and you see that sliding that happens. So it becomes a little bit frustrating. And so a hook plate certainly will keep that reduced and typically keep it reduced for a long period of time. It also, I think, allows for a less restrictive rehabilitation protocol. That's been mentioned in some of the papers. So you can be a little bit more aggressive if you have a patient that's non-compliant. That also allows for you to be a little bit more liberal with that particular patient. Unfortunately, though, it does have a high complication rate, and I think it increases pain relative to other procedures, and that's been demonstrated in the literature. It also causes a high rate of subacromial erosion, and I think that's why people do end up with pain, or potentially maybe causing some subacromial impingement or bursitis. And that obviously requires implant removal. Let's go ahead and go to the next slide. So, you know, and we can kind of breeze through these. There are, you know, the data that shows there's less loss of reduction. Next slide. There's also issues potentially with worse functional outcomes in the hook plate group versus double button reconstruction. So, and this is long-term at 2 years. Next slide. And then, of course, you know, you have the issues with complications that were demonstrated in this particular paper. Let's go to the next slide. So, and next slide again. And the complication rate really is fairly high. In some papers, upwards of 20 to 30%. So certainly, if you choose a hook plate, I think it's very important to pay attention to the patient's anatomy. So number one, one of the particularly important issues is if you have an AC joint that is 14 millimeters and you choose a 12 millimeter hook plate, you're putting quite a bit of undue tension on the undersurface of the acromion. You're probably gonna have a patient with significant trouble. And then there have been some good papers demonstrating that a 15-degree hook is a lot better than sort of a 90-degree hook in terms of spreading out the forces across the acromion. So I teach you know, my fellow to make sure that he has a good angle on the hook plate if he's going to utilize it. And also to make sure, you know, that hook plate shouldn't stay in for very long, probably at a maximum, you know, 3 to 4 months, and then the hook plate should come out. I'll go ahead and go to the next slide. So when do I use a hook plate to manage AC joint injuries? For me, it's this one sort of rare case, this unstable coracoid with associated AC joint injury to offload my coracoid screws. And then the second one is obviously sort of a chronic AC joint injury and concerns about a patient who may be non-compliant or an older patient to sort of hold that reduction while things heal, and then take that plate out later. Although that is also sort of a rare instance for me.
All right, that was a great talk and very balanced. Are there any questions, guys, regarding the hook plate? I tell you, Mike, my indications, the second indication you have there is when I've used them, really mostly when I'm worried about patient compliance. And I very much agree with you. I do think that when you put these in patients, they do hurt quite a bit. They really don't like them at all. And you definitely need to take them out. I've never tried bending it like that before. I'm not familiar with that concept. I'll have to look into that because that's interesting.
Yeah, I was going to show you guys a video of my patient that I just did. That was that patient I just showed. He's only about 6 weeks out, and he could only raise his arm to about 90 degrees. So I decided to withhold that from the presentation.
Yeah, he'll do much better once you get the hook out of him, right?
Exactly. That's exactly right.
All right, Brent, the floor is yours.
All right.
Guys, just to have, you only have 8 minutes, so.
Got it. We'll do the fast version. We can go ahead and skip ahead here. Thanks for having me. Thanks to the fellows for tuning in, either live or on delay. Congrats on finishing strong. So again, to highlight, we're dealing with the type 3 AC separation. This could be maybe considered to be a classic example, more than 100% separation. Again, we've been thinking of this problem in 2 dimensions. So we're going to talk a little bit today about the addition of some other variables. So we'll go ahead and skip ahead. So here's a patient, again, a right AC separation. Focus on the right scapular border, the medial scapular border. Clear example of scapular dyskinesis. So binary, yes or no. So this is evidence of scapular dyskinesis in a patient with the right AC separation. Why are we looking at that? Why is this the first time we've kind of looked at the scapula as we talk about this particular problem? We've alluded to this, but it's going to be a key as we maybe move forward with a more 3-dimensional thinking of how we diagnose and manage this problem. Next slide, please. So here's the classic thinking. We're all aware of this. This put us kind of on the right pathway. It gives us something that we can have thoughtful debate about, to publish research, but it's very challenging, and it clearly hasn't got us all on the same page on making the diagnosis and then translating that into the proper treatment. That's why there are over 100 published techniques. And tonight we've seen that between the 4 surgeons, at least 4, 5, or 6 different techniques. So very, very complicated. Next slide. So even looking at 2D versus actual 3D, so a 3D CT scan, which is not what we're talking about as far as the 3D pathoanatomy, but even that has not been helpful. So if you look at X-ray alone, looking at a 2D AP X-ray, not reliable. Adding a 3D CT, also not reliable. And Samer mentioned this idea too, and his looked beautiful. I mean, these are phenomenal surgeons. The cases look beautiful, but mentioned maybe over-reducing a little bit. But I know he mentioned just a little bit because I've seen other surgeons, other teachings that really over-reduce that a lot. But again, if we're really trying to reproduce the native and 3D anatomy, an anatomical reduction, I think, is in order. Next slide. So again, just to get in your mind's eye, so this is the same patient, but let's, instead of looking at a single 2D AP X-ray, we need to consider where that clavicle rests from an anterior to posterior position. That's where the clinical exam matters. That's where some of these tests matter. Next slide. So again, Dr. Levine, that was a beautiful unpaid ad by the president himself on the crossbody adduction view. I think this is important. This has been published upon with the ISICOS group. With my good friend, Dr. Kibler, Ben Kibler, Dr. Mazaka, and some of our thought leaders, people that really just sit around thinking about these problems. That's why I love this panel. These are difficult problems, and the fellows are going to help to drive us forward. So this is the cross-body adduction view, and they talk about the term overriding clavicle. So you take a 3, is it a 3A? Is it a 3B? Or as Steve mentioned, is a high 3 or a low 5. You know, it's complicated. So we have to move beyond static X-rays, but this gives us a little more dynamic here. So next slide. So again, that original X-ray that you have burned into your brain at this point, is that a type 3? What about this concept of a 3A, 3B? We're going to talk about that. It certainly hasn't solved the problem at all, but at least maybe we can start to think about this and move beyond the 2-dimensional thinking. Next. So again, how do we make the proper diagnosis? It's not just on an AP x-ray. So on physical examination, doing some manual dynamic AC joint tests. This cross-body adduction test as well with the radiograph can be helpful, but we'll show you some videos here of, as Ben calls it, Dr. Kibler, an anterior drawer test, and also some tests that typically can be provocative maneuvers, looking at your rotator cuff, but also how we can correct the deformity and see if the patient benefits from in the office correcting the deformity and see if that improves their function. And then the presence or absence of scapular dyskinesis. So again, our standard bilateral Zenka views, I think is beautiful. I don't personally do weights. I know Mike mentioned he'll add that sometimes with I think some like that, but I think this cross-body adduction view can be helpful. Next, please. So again, let's look at this drawer test. This is clearly an unstable. This is not an acute injury at this point. This is a chronic injury. So he's obviously allowing me to be a little more aggressive here, but clearly unstable horizontally, unstable vertically. And that looking at those features, most of us look at that. Next slide. So now I'm going to correct this. This is a scapular assistance test. With my left hand, I'm trying to correct that deformity. And now I'm trying to see if he improves. And so subjectively, he had improved. He struggled with this chronic injury for some time, struggling overhead. Now we're going to do a scapular retraction test, stabilizing that medial scapular border, helping to reduce that AC joint, again, for a chronic unstable injury. To add some of these different physical exam maneuvers to help you make your decision. Next slide. So again, it's hard to add formal definitions to these. This is what we use in our publication, and Steve mentioned similar criteria for his. So the idea of high grade, low grade, or 3A, 3B. So high grade, considering this to have vertical and horizontal instability when we're talking about these type 3 injuries with destruction of the CC and AC ligaments, and the presence of scapular dyskinesis, which we know is highly present in most shoulder injuries, but some people can compensate. Unfortunately, these patients cannot. So you can send these folks to therapy, see if they can improve and have the ability to compensate. But a lot of these patients will declare themselves with clinic follow-up and therapy. Next. So again, versus a low grade. So same clinical picture, but for whatever reason, they're able to compensate. So they don't present with the same high grade scapular dyskinesis, scapular dysfunction. Perhaps they do have a portion of the conoid still attached, maybe partially or fully, it's hard to know. But just like most injuries that we deal with in orthopedics, there are different shades here. So it's not necessarily a binary answer when it comes to the presence or absence of the ligaments. Next, please. So again, this committee put together, this has been several years ago now, this idea of a type A, type B. This does include the presence or absence of scapular dyskinesis, as well as this cross-body adduction view, specifically looking at the overriding clavicle. Hopefully to set the stage as we move forward here. Again, looking at type 3A and 3B. That's beautiful, Steve. You can press ahead there. So 3A would be what they considered a stable joint, no overriding on the crossbody or Basmania view, no scapular dyskinesis. This patient on the AP looks effectively exactly the same. They call it a type 3, but this helps us to hopefully better define this, again, adding clinical examination in this crossbody adduction view versus the 3B, which is unstable. So this patient is unable to compensate, and you can still go through physical therapy. The paper did highlight that a type 3A could effectively cross over to be a 3B if they fail physical therapy and non-operative measures. Next slide. So again, form follows function, these classic terms. This is a 3D problem with 3D dysfunction that needs a 3D solution. Next. So the paper is easy to grab. So it's a paper that we put together with Ben. This is his technique, which is modification of the Mazaka technique with clinical outcomes. And it really shows in the brief, no drill holes in the coracoid, 2 drill holes in the clavicle, 4.5 millimeters, so smaller based on the work that Dr. Brockmeier talked about with a lot of the iatrogenic fractures. It does involve biologics with the allograft and does involve the reconstruction of the AC ligament. So I agree with Steve, it's a CC and AC problem. And this image does show those native AC ligaments being repaired, usually with anchors as the ligaments avulse off of the clavicle side. You can actually go back and repair that as well. Next slide. So these are just some representations that can be viewed at a later time if you have interest in the technique. I don't think it's important for the fellows to adopt any one specific technique from tonight, but to learn how they can best diagnose, and then in their hands how they can treat this. Next slide. So again, this is showing both the CC and AC portion. That's a 2.4 millimeter drill bit to dock the ligaments into the acromion. So this is effectively a modification of the Mazzacca technique. So really all following the lead from the work that Dr. Mazzacca has done. Next slide. And again, the final construct, a couple views here for the final reconstruction. Next slide. So 2 case examples briefly. Again, now we're going back ironically to an AP X-ray to grade our work, right? So this was showing a type 3B that was unstable. And the next slide. So this was from the publication just showing that CC distance improved, but also we followed these up with clinical exam to ensure stability, anterior, posterior, vertical, and the absence of scapular dyskinesis. Next slide. So this is acute, high grade, a case of mine fairly recently, and same technique. Next slide. So no metal, no buttons, no plates, no implants. And the suture material that Ben has published on, and we published with PDS. You can look at other suture materials perhaps, and rarely will I ever resect any of the distal clavicle. I know we haven't talked much about that. This one I did take a little bit. It's pretty rare, as Sammer mentioned, in older patients. But for me, I preserve that strut axis. I keep the clavicle. Next slide. And this is acknowledgement to Ben. A lot of this work was from my time spent with him several years ago, and even as fellows, you pick up new techniques. We used a Weaver Dunn technique, and Brad Edwards is a master surgeon that, and had great results with that. But you pick up new things. I love the anatomical reconstruction, a modification of that Mazzacca technique. So big thanks to Ben Kibler for his mentorship on the AC joint side.
Thank you, everybody. It's 7 o'clock, and I appreciate everyone's time and energies for this session. We appreciate DJO, and we look forward to you joining us next week. Thank you, everybody. Good night.
Thanks, guys.
Thank you.
Thanks, everybody.
Thanks, everybody.
Thanks, Steve.
Thanks, Steve.